Hello everyone. So from today we've started head and neck. And the first structure which we are going to study in head and neck is scalp. Scalp refers to the soft tissue which is overlying the cranial vault. We will be studying two competencies regarding scalp. These are describe the layers of scalp, its blood supply, its nerve supply and surgical importance. Describe the emissary vein with its role in spread of infection from extracranial root to intracranial venous sinuses.
Now let's fast forward and imagine that you are an intern who's been posted to a PHC. And on your duty, and on this night duty which you're having, there is this case, a short-statured woman who goes for a prolonged labor of 12 hours. After 12 hours, she delivers a baby boy. So all the relatives are very happy. But after some time, some relatives come to you and start fighting with you because they see this dome-shaped deformity on the head of the child, on the infant. And they claim that you injured the child while you were delivering the child. So how will you save yourself and explain to them that what they are seeing is a normal condition? That the answer to this question we shall find in this particular class. Okay. Now one of your friends who is posted in LNJP hospital also comes across another case. In this particular scenario, what happened was this young man got into a fight and he got a blow on his head with a stick. उस समय तो उसको इतना दर्द हुआ थोड़ा बहुत वो जाके घर जाके he went off to sleep. Next day morning, when he got up and he looked into the mirror, he saw this purplish discoloration around his eye. So what happened in this particular case? So the answers to both these cases we will get in this particular lecture. So scalp, as we've studied, is the soft tissue which is overlying the cranial vault. So this is the cranial vault and the soft tissue, this soft tissue which we are seeing overlying it is the scalp. The scalp extends from the external occipital protuberance and the superior nuchal line, that is what was forming the junction of the head and neck posteriorly, all the way anteriorly up to the eyebrows or the supraorbital margins. Right? So this part of the forehead is shared by the face as well as the scalp. Laterally, this is the anterior posterior extent of the scalp. Laterally, it extends all the way up to the zygomatic arch. However, some books also say that it extends only up to the superficial temporal lines, but we will consider it that it extends all the way up to the zygomatic arch. The scalp, which is thus covering the bones of the skull, is not just mere skin. It has a depth to it and is considered to be made up of 5 layers. The first layer is the skin. Thereafter is a layer of connective tissue. The third layer is the aponeurosis. You remember what is an aponeurosis? Aponeurosis is a flattened tendon of a muscle. So that means some muscle is inserting out here and forming a flattened tendon, that is the aponeurosis. Thereafter, this space which you're seeing is the loose areolar connective tissue and then the pericranium of the cranial vault bones. So the layers of the scalp are skin, which stands for the S of the scalp, connective tissue, C of the scalp, aponeurosis, which stands for the word A, loose areolar tissue, that is for the L, and P, which is for the pericranium, which covers the cranial vault bones. So all these layers together form the scalp. Now let's study the layers of the scalp in detail. The first layer was the skin. Now please draw with me. Let's make the bones of the cranial vault. We are making a coronal section. Right? So we are going to go through the coronal suture. Let's draw the parietal bone of the left side. You know that it's a flat bone which is made up of compact bone on the outside and it has the cancellous bone or the diploe on the inside. Then this is the sagittal suture and this is the parietal bone of the other side. Oops. It's the parietal bone of the other side That is the right side with the cancellous bone or the diploid in between. Now the bones are lined on the outside, that is towards the outside, superiorly by the pericranium. So let's draw a layer of the pericranium, which is the last layer, the fifth layer of the scalp. Now this sagittal suture, which is present between the two parietal bones, this area, this has sutural ligaments which connect the pericranium, which is outside, with what is lining the bone on the inside, that is the dura mater. So let's draw that. So on the inside is the dura mater, right? This dura mater on the inside at this particular place is split into two at a place to enclose a venous sinus in between, which is a dural venous sinus. And the name of this dural venous sinus is the superior sagittal venous sinus. So let's give it blood because it's a venous sinus. Now, what is a venous sinus? What is this dural venous sinus? It is nothing but a collection. It is a drainage area where the blood from the brain as well as the blood from the inside of the cranial cavity is draining into these dural venous sinuses. And one of these dural venous sinuses, which is present out here, this is the superior sagittal sinus. Now, the pericranium on the outside is linked by means of sutural ligaments to the dura mater, which is on the inside. You know that the suture is an example of a fibrous joint, and this diagram out here shows you just the structure of a suture, which you did in general anatomy. So these are the parietal bones, which are lined by the pericranium on the outside and the dura on the inside. In this particular place where we're making a diagram in to do the layers of the scalp, the dura venous sinus in our body splits the dura mater splits to enclose to form an endosteal layer, and this here would be the meningeal layer, and it encloses between it a dural venous sinus, which is the superior sagittal sinus. Now यहाँ पर जो हम अभी नहीं बना रहे would be the other layers of the meninges and would be the right cerebral hemisphere on this side and the left cerebral hemisphere on this particular side. We are not drawing that now. When we do the interior of the cranium, we will further work on this particular diagram. Right now, we are using this diagram only to study the layers of the scalp. Now, right? So on the outside, that is superiorly in this section, out here would be the skin. The skin, as you are all aware, in most of us has hair follicles in it and has hair growing out from it. Right. So the skin of the scalp is the thickest skin which is present in the entire body. Is one of the thickest skins which are present in the entire body. And by thickest out here, I do not mean the histology of it, but I mean the thickness as a normal sense of thickness. Histologically, because it is bearing hair follicles, so you know that it is a thin, hairy skin. Histological is separate from just the thickness. That is a parameter, that it is thick, moti skin hai. But here, histologically, if we talk about it, it is nothing but thin, hairy skin, and thus it has with it hair follicles. It has sebaceous glands as well as sweat glands. You've already seen a slide of skin and you know how the thin hairy skin looks like. Now these sweat glands, open directly onto the outside, onto the skin. Now you are aware कि गर्मी होती है तो पसीना आता है और बाल में भी पसीना आता है. You also are aware कि बाल oily हो जाते हैं. So that means there are sebaceous glands which are present. So the maximum number of sebaceous glands which are present in the body are present in the skin of the scalp. Now these sebaceous glands, if you remember your previous histology lectures, you will remember that it opens into the duct of the hair follicles, right? And it secretes the secretion, that is sebum, onto the outside. Please try and remember what mode of secretion it was, right? Now, what is the importance of studying this here? Because when you go into the clinics, you will be seeing a large number of cases of sebaceous cysts of the scalp. So what is a sebaceous cyst? Now, while we are combing, sometimes we comb vigorously, or there may be dandruff which gets accumulated in the scalp, or if there is an infection in the scalp. This results in blockage of these ducts of the sebaceous gland. So these duct of this, if suppose this duct of the sebaceous gland gets blocked, what will happen? The secretions will start accumulating within this duct, within this gland, and ultimately this gland will enlarge, like you can see out here, and it will be filled with secretions, and this results in a condition called sebaceous cyst. So when the duct gets obstructed or blocked, there is retention of secretions and results in the formation of cysts on the scalp, which are also known as sebaceous cysts, which you will be seeing when you go into their clinics. Underlying the skin is the next layer, which is the layer of the connective tissue or the dense subcutaneous tissue. Now within the same diagram, let's go further on. The third layer is the aponeurotic layer. To be able to understand this diagram better, so we need to draw the third layer. First, we'll discuss the third layer in detail in the next slide. So let's draw the third layer, which is the aponeurosis. So this is the third layer, which is the aponeurosis. Now, in between the skin and the aponeurosis is going to be made the second layer, which is the connective tissue layer. Right? So we'll make the connective tissue layer. The connective tissue is the fibro-fatty tissue. So let's make the fat. So ये fat हो गया. That covers the fat component of the fibro-fatty. And what do you mean by fibro? That is, there are septa, fibrous septa, which are running from the skin to the underlying aponeurosis and connecting them. This results in dividing the fat. So these fibrous septa divide the fat. So look at this area. This fat out here has got loculated. So the fibrous septa loculate the fat or made small pockets of the fat are formed. Also present here is rich blood supply. The blood supply, also present here are the blood vessels and the nerves which supply the scalp. So let's draw the blood vessels. Now, one characteristic feature of these blood vessels are that their walls are adherent. The walls of these blood vessels are adherent to the fibrous septa. So if I was to draw an artery and a vein, so I'm drawing an arteries, the arteries first. The walls of these blood vessels are adherent to the fibrous septa. There are also present veins with the with the arteries. So it has a large number of arteries and veins running through it, and also present are nerves. Right? So the connective tissue consists of fibrofatty tissue, right? It consists of the fibrofatty tissue. It consists of arteries, veins, and nerves. This layer also contains the arteries, veins, and nerves which are running in it. The fat has got loculated in small pockets by means of this fibrous septa, which are running from the overlying skin to the underlying aponeurosis. Now, what happens? What are the clinical conditions which arise as a consequence to this anatomy, which is of the connective tissue layer? Number one, normally, this is the area which has the richest blood supply in the body. A large number of blood vessels, which are branches, the arteries, which are branches of the external carotid artery and branches of the internal carotid artery, are forming an anastomosis in the scalp. So it has a rich blood supply. The rich blood supply means that it has a very good healing. If there is a wound which takes place in the scalp, the healing is very good. But it also because of the rich blood supply, wounds of the scalp tend to bleed profusely. So wounds of the scalp heal well, but wounds of the scalp also bleed profusely. Now, why is this profuse bleeding taking place? Number one, because it has a rich blood supply. We just talked about it. We will be talking in detail about what blood vessels are supplying it in a few minutes. Number two, the other important factor. Look at this. The blood vessels, the walls of the blood vessels are adherent to the fibrous septa. Blood vessel walls are adherent to the fibrous septa. As a result, the first step for the bleeding to stop normally is that the blood vessels should be able to retract. These blood vessels are unable to retract. So as a result, bleeding takes place profusely. The only way the bleeding can be arrested is by pressing that blood vessel where the area where it is bleeding against the underlying bone. Okay? Now, the other thing which happens is because there is so much of fatty tissue which is present out here. Now, this fatty tissue can get infected and inflamed. या तो blood vessels में से कभी-कभी bleeding हो जाती है या कोई bacteria which is running through these blood vessels may enter into this fibrous fatty area. As a result, this fatty tissue gets inflamed. Now, this is unyielding. We just talked about how the fibrous septa is connecting the skin to the underlying aponeurosis, and this is making these fatty pockets loculated or making these fat pockets which are present out here. So now, if there is a space occupying lesion due to inflammation हुई, various edema होना शुरू हो गया, the body is trying to fight it back, edema हो रहा है, तो यहाँ पर accumulation of fluid starts taking place. As a result of it, ये जो nerve endings है, they get stimulated. So swellings of this particular area are highly painful. That is because, number one, because of the fibrous septa which are running between the skin as well as the underlying aponeurosis, it forms an this layer is unyielding, and inflammation or any space occupying lesion tends to irritate these nerves, which are also a large number of nerves are also present in the scalp. So these nerves get irritated, and this results in painful swellings in case of inflammation of this particular area. Now let's go to the third layer. The third layer is the aponeurotic layer, what we have been talking about till now, the aponeurosis. This aponeurosis is also known as Galia aponeurotica. But ये किसका aponeurosis है? There's an aponeurosis of a muscle of the scalp, which is the occipitofrontalis muscle. That is, there are two bellies, a frontal belly and an occipital belly, which are together forming this muscle, the occipitofrontalis muscle. So this is the occipital belly, then there is the aponeurosis, and this is the frontal belly. This is the muscle which is present in the face. Now there's a characteristic feature of the muscles of the face. At one end, they are going to be attached to the bone, and on the other end, they are attached to the overlying skin and the connective tissue. Right? So that's how the muscles of the face are very different from the muscles which you've been studying till now in the limbs, which were attached by means of tendon on both sides to the bones. Now, the occipitofrontalis muscle consists of two bellies. Now, let's start again by making a diagram. That other diagram we will complete, but this is a new diagram which we are making, which we need for understanding certain concepts. So let's make a parasagittal section through the scalp. So let's make the bone again. Now we are making the entire. So we are making the frontal bone, we are making the parietal bone, and we are making the occipital bone. Sari bones are bana rahe. So this is the frontal bone, and this is the frontal, and out here would be the nasal sinus, frontal nasal sinus, which is present. और ये हमने frontal bone को आगे ले, ठीक है? ये पूरा पीछे तक ले आते हैं इसका inner vault को, और इसी के ऊपर हम बना लेते हैं अपना outer vault और ये external occipital protuberance. ये तो external occipital protuberance तो नहीं होगी because we are making a parasagittal section. तो हम थोड़ा external occipital protuberance के side पर है, ठीक है? Superior nuchal line के पास है posteriorly. So this is the frontal bone in front. और ये हो गया occipital bone at the back. This is the outer vault of the cranial bone, and this is the inner vault, and in between let's put the diploe again, the cancellous bone or the diploe which is present out here again. Okay, let's draw the outermost layer, which was the skin, the hair follicles, the underlying fibrofatty tissue, इसमें हमने blood vessels डाल देंगे, nerves डाल देते हैं, And let's put in the wheels also somewhere. And let's draw the septa, which are going to connect it to the aponeurosis. Now the aponeurosis, now I'm going to use another color for the aponeurosis. I'm going to use green. Now the aponeurosis per se is present only in the middle. In front, it is a muscle is attaching to it. As you can see out here, this is present only in the middle. There's a muscle attaching to it in the front, and there's a muscle attaching to it posteriorly. Now let's start with the occipital belly of this. So the occipital muscle arises, the occipitalis part of the occipitofrontalis muscle arises from, again, I don't have the brown, so I'm going to use this mustard for the muscle. It arises from the lateral two-third. The occipital belly arises from the lateral two-third of the superior nuchal line. Remember, the superior nuchal line was a line which was running from the external occipital protuberance towards the mastoid process. So from the lateral two-third of this arises the occipital belly. So out here, let me draw the occipital belly, which arises from the bone, out here, the superior nuchal line, and inserts into this and then forms a flattened tendon, which is the Galea aponeurotica. Anteriorly, this aponeurosis has the frontalis muscle which is arising from it, which does not have any bony attachment. I just told you that this muscle attaches to the skin and the connective tissue like the other muscles of the face. And where does it attach? To the skin of the eyebrows. It attaches to the skin which is present around the eyebrows, as well as you can see in this particular diagram, it gets continuous with the other muscle which is going to be present around the orbit and is the muscle of the eyelid, the orbicularis oculi. So this is an important thing which you need to remember, that the frontalis muscle, which is present anteriorly, attaches to the epicranial aponeurosis on one end, and on the other end it goes and attaches to the skin of the eyebrows as well as the skin of the eyelids, as well as gets continuous with the orbicularis oculi muscle. Okay? So we have two bellies. One is the occipital belly and we have the frontal belly, and let's line them. Okay? And they are enclosed by this particular arch. The occipital belly is attached posteriorly to the superior nuchal lines, whereas the epicranial, and the other end it gets attached to the epicranial aponeurosis, and the frontal belly is also attached to the epicranial aponeurosis, but on the other side is attached to the skin and the connective tissue. It has no bony attachment. The point to remember is that it has no bony attachment. Another important thing to remember about these muscles are that the frontal bellies, look at the frontal bellies. The two bellies lie side by side to each other. They are in close contact with each other with very little aponeurosis in between them. But look at the occipital bellies. The Galea aponeurotica or the epicranial aponeurosis comes and gets attached to the external occipital protuberance as well as to the superior nuchal lines on posteriorly. Even laterally, this epicranial aponeurosis goes and gets attached all the way down to the zygomatic arch. And that is why I said that we will consider the scalp to be extending all the way up to the zygomatic arch. So it moves over this muscle which is present, the temporalis muscle, and goes and gets attached to this zygomatic arch which is present laterally. Now, what is the nerve supply? These will be supplied by branches of the facial nerve. We haven't done the facial nerve. I know you don't know anything about it, but presently, just take my word for it, that the frontal bellies are supplied by the temporal branches of the facial nerve. If you remember facial nerve, good enough, but we will have to remember this. So by the temporal branches of the facial nerve for the frontal bellies, and the occipital bellies are supplied by the posterior auricular nerve. Kaan ke piche, posterior auricular nerves supply the occipital bellies. Whereas ये temple के पास है, तो temporal branches of the facial nerve supplies the frontal bellies, and the occipital bellies are supplied by the posterior auricular branch of the facial nerve. So action क्या होगा? So what is the action? Yes, the frontal bellies are used to elevate the eyebrows to give the expression of surprise or horror. Okay, and they also, now move your eyebrows upwards in that expression of surprise. You can feel now your entire, you can feel the frontal bellies contracted all the way. You can even feel your occipital bellies. The occipital bellies, on the other hand, draw the scalp backwards. So that is the action of these two muscles. So what is the applied anatomy of the scalp vis-a-vis the third layer? The wounds of the scalp gape if the aponeurosis is divided transversely. So if there is a transverse cut in the scalp like this, and it's a deep cut, the frontal belly will pull this forward. The occipital belly will pull this part of the wound back, of the skin backwards. As a result, the wounds tend to gape. That is, the wound gets separated. The skin gets separated, and it requires suturing. On the other hand, if it's a transversely running, if it's sagittally running, if there is a cut which is placed like this sagittally placed wound tends to remain closed. Now also this layer, because of the muscles which are present in it, there is a mobility to it. So as a result, the wound in the scalp, in the skin, may not overlie the fracture. So if there is a blow and it results in fracture of the cranial wall, the fracture की site और skin की site में शायद अंतर हो सकता है. This is because of the fact that this layer is a mobile layer. It is because, and the three layers which we talked about, this, that is the layer 1, which is the skin, the layer 2, which is the connective tissue, and the layer 3, which is the aponeurosis. They are connected to each other by means of those fibrous septa, and they tend to move together and form the surgical layers of the scalp. Number 1. Number 2, if there is injury and the scalping takes place or the avulsion takes place, suppose the hair gets caught in some, it's horrible, but if it gets caught in some machinery and the scalp gets avulsed, so what will happen? These three layers, these surgical layers of the scalp, or these three layers, the layer 1, the layer 2, and the layer 3, tend to move together. Also, surgically, if we want to remove the scalp, if we want to take the scalp graft and we want to put it somewhere else, or we want to remove the scalp, these three layers again are moved together. You cannot separate these layers. You separate these three layers from the underlying pericranium through the loose areolar tissue layer, which is the next layer which we are going to study. Layer, which is underlying the aponeurotic layer, and the muscle layer is the loose areolar tissue layer. So this would be the loose areolar tissue layer, right? So this layer separates the aponeurosis from the underlying pericranium. Aponeurosis from the underlying pericranium. Now, why is this layer important? Because resting in this loose areolar tissue which is present are emissary veins. These are veins which connect the extracranial veins of this which were lying in the scalp. These veins to the underlying veins, the intracranial venous sinuses. And also they connect the veins, these veins also connect to the veins which are running in the bones, the diploid veins which are present out here. So these veins are highly important and they are known as the emissary veins, which are present in the loose areolar tissue. They are connecting the overlying extracranial veins, which are veins of the scalp, to the dural venous sinuses which are present inside the cranial cavity. So why are they there? In case there is a thrombosis in this sinus due to infection, inflammation, as a result, there is this alternate way of drainage of the blood which can go now from the intracranial tissue outside to the extracranial. However, not only that the blood can move, also what happens is infections of the scalp or infections which are present out here, the inflammations which we talked about, can move from the extracranial route, from these extracranial via these emissary veins into the intracranial veins, and that is an extracranial infection or infection from the outside has reached inside the cranial cavity, and you can imagine how hazardous this could be. So as a result of it, this loose areolar tissue layer which houses these emissary veins is also known as the dangerous area of the scalp, because these veins, which are valveless, they are important. They become especially important because sometimes they can result in spreading of infection from an extracranial area into an intracranial area. Now, where have we seen emissary veins? When you do the parietal foraminas, you will find, when you see the parietal foramina in the parietal bones, you will see parietal emissary vein. You will be told about or you will read about the parietal emissary vein, which connects the veins of the scalp, the extracranial veins, again with the superior sagittal sinus. Similarly, when you look at the mastoid foramens, you will see the mastoid emissary veins, which is going to be connecting the veins which are present in the scalp posteriorly with the veins with the sigmoid venous sinus, which is again another important, very, very important venous sinus which is present in the cranial cavity. Now, there's another important applied anatomy which is sometimes talked about in the case of the loose areolar tissue, and that is the safety valve hematoma. Now, in children, unlike in adults, the pericranium is tightly adherent to the underlying bone. This pericranium layer is tightly adherent to the bone, and so also the dura mater is tightly adherent to the bone. This is not so. That's not the case in adults. As a result, if there is a fracture of this bone and there is an intracranial bleed because of this particular fracture, ये जो intracranial bleed होगी, जो यहाँ पर bleeding होगी, it moves through the fracture lines and can, because ये adherent है, तो ये जो pericranium है वो भी फटेगा और ये dura है वो भी फटेगा, and as a result the bleed will move from this area, that is from the inside, it will move outside and the blood will come and lie in this particular area, which is the loose areolar tissue. क्यों? क्योंकि pericranium tightly adherent है to the underlying bone and the dura is also tightly adherent. So जब fracture हुआ तो pericranium भी फटा और dura भी फटा. So blood बाहर निकल गया instead of accumulating within the cranial cavity, and as a result of which the signs of intracranial compression did not arise, and thus this is known as a safety valve hematoma, which is a condition which is only seen in children, and it is not seen in children and it is not seen in adults. Now, there's another very important applied anatomy, and a question which is associated with the loose areolar tissue is the layer of the scalp, is the condition black eye. So remember the LNJP intern had seen a case in which the man had come to us with the complaint of purplish discoloration around the eye. So there is purplish discoloration which takes place around the eye, bluish purplish discoloration which is known as the black eye. So if remember, that gentleman had been hit on his head by a stick, and a day later when he got up in the morning, he saw that his eye was discolored. Now what would have happened in that particular case? When bleeding takes place in this loose areolar tissue, say these emissary veins or one of these veins gets ruptured due to the blow. Now this blood can easily, now where will this blood go? It cannot track down further down from the occipital region, because here the occipital belly and the Galea aponeurosis is attached to the epicranial aponeurosis as well as the superior nuchal line. So when the blood tracks down, it gets stopped out here. Now, laterally, if the blood tends to move, you know that the Galea aponeurosis was getting attached to the zygomatic arch. So laterally also it cannot move anywhere else. But anteriorly, the frontalis belly had no attachment to the bone. Do you remember that? We had discussed that there was no bony attachment for this frontalis belly of the occipitofrontalis, and also that this was getting continuous with the muscle of the eyelid. So the blood which is present in this layer, in the loose areolar tissue, gravitates downwards slowly and it moves into the area of the upper eyelid and around the eyelid in the subcutaneous tissue of the eyelid, resulting in blackish discoloration. So, if there is bleeding, if it takes place in the loose areolar tissue, the blood tends to gravitate or move slowly downwards to the area of the eyelid, to the region around the eyelid, because the frontalis belly is not attached. The frontalis belly or the frontal bone is not attached. Muscle does not have a bony attachment. And this results in a condition called the black eye. And this was the reason for black eye which took place in our intern. Another reason why black eye can take place if there is a fracture of the skull base. If there is a fracture of the orbital plate, this plate, the orbital plate, this is going to be this. इसके नीचे यहाँ पर orbit होगा. If this orbital plate of the frontal bone gets fractured, again it would result in a condition of black eye. Or there is a direct violence to the eye. सीधा मुक्का मारा आँख पर, again it would result in this condition of black eye. So bleeding and in the loose areolar tissue, orbital fracture, fracture of the orbital plate of bone, or a direct violence on the eye would result in the condition of black eye. And with scalp, the important reason is that bleeding taking place in the fourth layer or the loose areolar tissue layer. The last layer, the pericranium. Now this is a diagram which I have taken from the Snell's anatomy. So see that you draw it in your files, and this is what I helped you to draw, the coronal section of the upper part of the head showing the layers of the scalp. Now, and we are drawing again in the area of the sagittal suture of the skull. We haven't discussed this part. We will discuss it and we will put in this part later. So the last layer which we are going to talk about is the pericranium, which is nothing but the periosteum of the cranial bones. So in this particular diagram, it would be the periosteum of the parietal bone. Otherwise, it could be the periosteal layer of the frontal or of the occipital or the temporal bones, depending on where we are talking, which section, which part of the skull from which we are taking of the section of the scalp. So this pericranium is loosely attached to the underlying bone in adults, except in the areas of the sutures, where by means of sutural ligament, it gets attached to the underlying dura, right? So with this, we complete the layers of the scalp. Now let's study about what is the blood supply and the nerve supply. The head and neck receives its blood supply from the carotids, with some reinforcements coming from the from the subclavian arteries. Now, the common carotids, which are direct or indirect branches of the arch of aorta, divide at the level of the upper border of thyroid cartilage into an external carotid artery and an internal carotid artery. The external carotid artery basically supplies the entire neck region as well as the external, all what we are seeing on the outside of the head and neck. The internal carotid artery supplies the brain and the brain. Now, the scalp, on the other hand, is the site of anastomosis of the external carotid and the internal carotid. So, it's receiving its blood supply from branches of the external carotid and the internal carotid. Now, you've not seen these branches, but I'll walk you through with them, and over a period of time, you'll get to know where and how they're coming from. So, let's draw a section of the, not a section, let's draw a view of the scalp when viewed from above. So the head or the scalp when viewed from above is narrower in the front and broader at the back. Let me just change its position to be more on the center. Okay, so this is the frontal area, the parietal, and in the end, terminally, or at the back is the occipital area. Okay, हमारे skull पे थोड़ा सा distortion हो गया है, but let's try it again. Right. Now, On one side, I'm going to draw the arterial supply, and on the other side, I'm going to talk about the venous drainage. So I'm going to divide it into two halves. This is the auricle, which we're using as a landmark. All right. Now, anterior to the auricle lies a branch, which is a terminal branch of the external carotid artery, which is the superficial temporal artery. So this is the superficial temporal artery, a terminal branch of the external carotid artery. Now, this branch you can even palpate on your own. It is present anterior to the pinna of the auricle. So if you press against the mandible, head of the mandible in front of your auricle, you will be able to feel the pulsations of the superficial temporal artery. And because the pulsations are felt, it is also known as the anesthetist. It is also known as the anesthetist artery, because while the surgeon is performing surgery on a patient which is under anesthesia, the anesthetist uses it to palpate the pulses, to assess the pulses, right? So it's the terminal branch of the external carotid artery, and its position is that it is running anterior to the auricle, and in the scalp also it comes anterior to the auricle and supplies this area of the scalp. Now, posterior to the auricle is the posterior auricular artery, which is also a branch of the external carotid artery, right? Posterior auricular artery. And in the area of the occiput, the terminal portion of the occipital artery are seen. So all these arteries are branches of the external carotid artery. Now, what branches of the internal carotid arteries? Now, anteriorly from the orbit, from the area of the orbit, in the area of the orbit, the orbit is being supplied by the ophthalmic artery, which is a branch of the internal carotid artery. Now, its two terminal branches, after having supplied the orbit and the skin over the forehead and all the areas, it comes ultimately, they come and terminate in the area of the scalp. These are medially placed supratrochlear artery and lateral to it, the supraorbital artery. So the supratrochlear artery and the supraorbital artery. These two arteries are branches of the internal carotid artery, while the rest of it are the branches of the external carotid artery. So, one, we have a large number of blood vessels which are supplying the arteries, which are supplying the area of the scalp. There is an anastomosis taking place between external carotid artery branches and the internal carotid artery. It is because of the rich blood supply, wounds of the scalp tend to heal well, and at the same time, wounds of the scalp tend to bleed profusely. We have discussed these things about the scalp, and all these blood vessels, the nerves, the veins, the arteries, all of them are running in the layer 2 of the scalp. That is the connective tissue layer of the scalp. Now, the veins follow the artery, but the direction of the blood flow is opposite. So again, if we were to draw the veins, here would be the supratrochlear vein, but which is the direction of blood flow? This way, going towards the face. And here would be the supraorbital artery. So they're draining away from the scalp towards the face in the layer 2. Now these two blood vessels join in the area of the face and they ultimately drain and form a facial vein. So आगे से they are coming from the scalp towards the forehead, and at the medial canthus of the eye, they join together at that area and form this vein, which is the facial vein. They join together and form the facial vein. In front of the auricle, draining this area, would be the superficial temporal vein. This superficial temporal vein will be one of the formative tributaries of the retromandibular vein. So ultimately, it will drain into the retromandibular vein. What is this? This is the superficial temporal vein. Posterior to the auricle is the posterior auricular vein. Posterior auricular vein, which will ultimately drain into external jugular vein. So now all the the venous drainage will ultimately go via the jugular's back. All right, so they will drain directly or indirectly into the jugular veins. And posteriorly will be the suboccipital. This will be the occipital veins, which will drain. So this will be the direction of blood flow, which would drain into the occipital vein, which will drain into the suboccipital plexus. Okay. Now, so the the venous blood is draining from the scalp downwards. It's going because it has to ultimately go to the heart. Now, remember our case of the PHC, where the intern had to face the angry relatives who said that swollen edematous scalp, or that deformed scalp which the patients were seeing on the newborn was a consequence to the injury which had been inflicted by this intern. So what had actually happened? Now all these veins take the blood from the area of the scalp towards the neck. Now during delivery, right? During delivery, and especially if the delivery is prolonged. So the woman in our case also had a prolonged labor. During delivery, especially when there is a prolonged labor, the head gets stuck. The fetal head gets compressed for a long period against the female pelvis. Right? So it gets compressed against the female pelvis for a long period of time. As a result, the venous drainage gets affected and there is engorgement of these veins. So अगर यहाँ पर compression, ये इस area में compression हो रहा है, तो यहाँ से जो venous blood जा रहा है, वो नहीं जा पा रहा. There is engorgement. Engorgement of veins results in a swollen and edematous scalp, and this condition is known as caput succedaneum. And it's a normal condition which usually subsides on its own in 24 to 48 hours. So all that the intern needs to do is explain this carefully to the relative that it's a normal condition, it will subside on its own. So this is about the arterial and venous drainage, which we see in case of scalp, and we've already discussed the emissary veins. Please see to it that you are able to write a short note on the emissary veins. Now let's discuss the nerve supply of the scalp. The scalp has skin, it has the superficial fascia as well as muscle. So it should get a sensory nerve supply as well as a motor nerve supply. So the sensory innervation of the scalp, of the region which is lying in front of the imaginary line which is running from the vertex to the auricle, is under the domain of a cranial nerve, which is the trigeminal nerve. The area posterior to this imaginary line, is supplied by branches of the cervical nerves. Now what are these? Let's see. Accompanying the supratrochlear and supraorbital branches of the internal carotid artery, which were branches of the ophthalmic artery. Now we have a supratrochlear nerve and a supraorbital nerve. These nerves, supratrochlear as well as the supraorbital nerve, are branches of the ophthalmic division of the trigeminal nerve, which is the first division of the trigeminal nerve. So we also call it as 5-1. Now, these nerves together supply the area of the forehead, the skin of the forehead, as well as the adjoining area of the scalp. Innervating the side of the scalp, which is above the temple, are two nerves. One, this is the zygomatic-temporal nerve, which is a branch of the second division of the trigeminal nerve, which is the maxillary nerve, and anterior to the ear, superior and anterior to the ear, the area of the skin is supplied by the auriculotemporal nerve, which is a branch of the mandibular division and accompanies the superficial temporal artery. The area behind the ear is supplied by this part. This is supplied by the lesser occipital nerve. This is a branch of the cervical. It is the branch of second cervical nerve. More posteriorly, it is supplied by the greater occipital nerve, which is the thickest cutaneous nerve. The greater occipital nerve, which is the thickest cutaneous nerve, which is present in the body, which is the dorsal ramus of C2. And the posterior part of the scalp is supplied by third occipital nerve. So all these structures, which is the dorsal ramus of C3. Now these are the sensory nerves which are supplying the scalp. Now what about the muscles? The frontal belly of the occipitofrontalis is supplied by the temporal branch of the facial nerve. The temporal branch of the facial nerve, which is the motor nerve which is supplying it, and the occipital belly, the occipital belly is supplied by posterior auricular nerve, which is again a branch of facial nerve. So this is how the scalp is supplied by sensory supply by trigeminal nerve as well as the cervical nerves, and motor supply by the facial branches of facial. And lastly, the lymphatic drainage of the scalp. There are no lymph nodes which are present in the scalp. Again, the imaginary line from the vertex to the ear, this imaginary line is the watershed line. The area posterior to it of the scalp drains into the occipital and the mastoid group of lymph nodes. So posterior part of the scalp will drain into the occipital, which are present out here, group of lymph nodes, and the mastoid group of lymph nodes, which will be present out here. The area anterior to this imaginary line drains into the parotid group of lymph nodes, which is present around the parotid gland. So with this, we come to the end of this lecture. Please see that there are certain important diagrams which you draw in your files. One is the coronal section of the upper part of the head showing the layers of the scalp, which we've drawn together. And I've told you again, this is a diagram from Snell's. The second is this section which we drew from which is the sagittal section of the layer showing the layers of the scalp, which is very important when you're talking about the question on black eye. So you should be able to draw this also. And the third important one is the blood supply and the nerve supply of the scalp, a diagram depicting the blood supply and the nerve supply of the scalp. So thank you and see you again in the next lecture.